Okay, I'm going to bring us all together here. We've got an hour and a half today, and you'll be astonished at how quickly it's going to go. So let's not wait too much longer for people to get here. They'll come in, they'll get their lunch. It is an honor to convene this meeting today. We have two world-class scientists who are leading in our field in terms of biomedical prevention and biobehavioral HIV prevention. And we're going to hear from these folks today, Chris and Jane, about how we're going to get to 2020, some of the top challenges we have in our field in prevention and getting there. I'm stealing this topic, of course, from Carl Dieffenbach, who has been famous about going from room to room saying, tell me what we need to do to get to 2020. It's a little late to do this because we've got 2 more years, but I think it's a good idea to kind of start getting that sort of next field of vision that'll help us with the longer arc of our work as we think about this moving forward. We're going to start with Chris is going to give a talk, and then Jane is going to give a talk after that, and then we're going to open up for discussion. So that's the structure of the day. Please come in, grab lunch. Oh, hey guys. So it's my great pleasure to introduce Chris Beyrer. He is the Desmond Tutu Professor of Public Health and Human Rights at the Johns Hopkins Bloomberg School of Public Health in Baltimore. He's a Professor of Epidemiology, International Health, has an amazingly impressive portfolio of work, and has really been guiding us in lots of ways in terms of biomedical HIV prevention. He is the prior president of the International AIDS Society. So I could go on and on. He's done so much work, and one of the greatest things is he comes and talks to us. That's very cool. So I'm very grateful for that. He's in a lot of network studies, and today he's going to talk with us about the top challenges in biomedical HIV prevention. Chris?
Well, thanks so much, Steve, and wonderful to be here. I've only been here 2 days, I think, or 2.5 days, but it feels as though lots of wonderful new friendships and reestablishment of existing ones. And we got to honor Tom Coates yesterday, which was wonderful, a mentor and research collaborator of mine for many years. I don't know how long HP 10043 actually ran. How long did it run?
About 100 years.
Yes. It went on for a long time. Anyway, but it really is wonderful to be here. And we had for those of you who participated yesterday in the CHIPTS retreat, I think we had a very rich day talking about a lot of these issues. I actually got up early this morning and played around with this talk a little bit to try and reflect some more of what came out of our conversations and work together. It really was a wonderful day. And I think just before I begin, let me just say that first of all, we're not going to make these goals by 2020. 2020 is 18 months away, and we are not there. So let's just get that out of the way. There is an enormous amount of undone work. A lot of it is implementation, a lot of it is public health work, but there's also a research agenda for the next phase of the HIV response that in some ways is going to be the hardest part. When you think about places that are achieving 90-90-90 and the successes there, we have to remember that it's often the last mile, the 10-10-10 and the 5-5-5, that actually is the hardest part, right? And you've already taken care of the problems that are fixable and solvable. So that is to say, particularly to the young people in the audience, and I have to say, it's a wonderfully youthful group here, so many of the Fogarty fellows and students. There is a lot of work ahead in the HIV response. I'm going to start by talking just a little bit about global epidemiology and essentially why we're not going to make these 2020 targets, which I think is important to think about. And then I'm just going to focus on 2 populations, both of which are very richly represented in your research efforts here and program efforts. That's people who inject drugs, and then gay, bisexual, and other men who have sex with men. And the way that Jane and I have discussed sort of handling this morning, this afternoon, is that I'm going to talk more about the levels beyond the individual and the couple, so more of the network, challenges, social, structural, and then she is going to take us down to that critical level of the individual and the dyad, and then hopefully we'll in the discussions, we'll be able to bring that all together. So of course, there's been a lot of rhetoric and a lot of discussion about whether or not control of the HIV pandemic is achievable. There's a lot of different ways people have phrased this. Is ending AIDS as a public health threat achievable? This was an influential paper in AIDS that looked basically at the curve of the epidemic and where it's going. The status quo, which was a slow decline in new infections, is not sufficient to end the epidemic. So what are the things that could really make a difference? In this modeling exercise, I also included this because behavior is here. You're behaviorists. It remains an important part of the portfolio. But basically, it's getting people tested, getting people living with HIV on therapy as soon as possible, keeping them on therapy, of course, at least for now, daily oral for life. Doing better with some of the biomedical interventions we have, like circumcision, early ART, structural interventions, PrEP. And basically the argument is if you could do all of these things, yes, we have the tools right now without a vaccine, without a cure, without some of the new prevention technologies that are in the pipeline to actually achieve epidemic control. So the answer for this group anyway was yes, it's achievable, but we're not going to be able to eradicate HIV. So Diane Havler and I weighed in on this issue. We were working on the AIDS conference in 2012 in Washington. And basically reviewed what was out there in the data and the really critical advances that all of you are very familiar with, and perhaps the most important one being that treatment really has an enormous preventive impact that led to a great deal of the optimism in this field. So where are we, and why is it if we have these powerful tools, we're not achieving control? So of course, we always have to acknowledge that we've already lost close to 40 million of our brothers and sisters to this epidemic. There still are close to 37 million people living with HIV. That's a pretty wide range because of the surveillance estimates. We had in 2016, and this will be updated, we'll see the 2017 totals in Amsterdam this summer at the AIDS conference, about 1.8 million new infections. That is relatively conservative as an estimate, 1.6 to 2 million. And that is really the rub. The reason I've highlighted this in red is because we're not going to achieve epidemic control with that number of new infections. I'll show you a little bit of data from Russia that will suggest that you should probably add about 100,000 additional infections just from Russia alone, actually, to that number. But remarkably enough, more than half of those people living with HIV on antiviral therapy. And that is probably the most significant global health achievement of the last decades. It's an unbelievable thing, and we should remember that the US has been an essential donor in that space. We now account for a little over half of the donor funds going to this, and that achievement is fragile. It is not guaranteed, and of course, reductions in funding and program cutbacks could lead to people getting into trouble, staying on therapy long term. Only about 40 countries, a little more than that now, implementing PrEP, and certainly virtually nowhere, including, of course, in the US, which is the first country to do this, have we achieved anywhere near the numbers we need to see to really have a public health impact. But encouragingly, a number of countries getting on board. So what is not going well? This is data some of you may know from UNAIDS, a GAP report. I think it very nicely illustrates this is incident HIV infections globally, so it's new infections. And this is what has got everybody so excited, the declines in new infections in Eastern and Southern Africa and what had been really the hyper-epidemic zones. That's a decline. That is something to celebrate. That cost billions of dollars and a huge amount of effort. How steep a decline is that? You're all budding epidemiologists. Are you excited about that? You think that's good enough? Are we there? When you look at most of these other curves, you see that actually they're pretty flat. They're pretty flat. But two of them are actually expanding, and there are two regions where HIV is continuing to expand. This is Eastern Europe and Central Asia, and most of that is Russia. The other is the Middle East and North Africa. So they needed another social and public health problem, but nevertheless, that is really troubling. So when people talk about reaching these 2020 targets and the end of AIDS, and it's going so well, you have to say, yeah, except for Eastern Europe, Central Asia, the Middle East and North Africa, and key populations in many other places. In 2016, there was a UN high-level meeting on ending AIDS. It actually turned out to be a very problematic meeting. We'll talk about that maybe later. But at that, Tony Fauci gave a really quite extraordinary talk, and he presented this slide, which he kindly shared with me, which is basically the global arc of new HIV infections in adults across the span of this epidemic, right? And this is our problem, that incident infections have largely flatlined. There is maybe modest decline there, and we are not achieving control of new infections at the rate that we need to. Now, happily, in the current Office of AIDS Research, NIH priorities that are shaping the future of the NIH research agenda, the number one priority is reducing the incidence of HIV. Isn't that thrilling? By the way, this is now is open for public comment. The next iteration of the OAR priorities is being worked on, and I really encourage all of you to take a look at those and weigh in on what you think are the important new changes to this. I would just underscore that across these, which is also therapeutics, cure, and comorbidities, that there are a series of cross-cutting themes that play very important roles in this plan, and that includes basic research, health disparities research, very important part of your portfolio, but also international and domestic training. Of course, UCLA is an extraordinary place in that regard. Roger has been one of the great leaders of doing international training with poverty support and others. So we have regions where we have expanding epidemics, and then we have populations where we're seeing sustained incidence, or in some cases rising incidence. And I am just going to focus on two, that is people who inject drugs and gay and other MSM. So a little bit about key populations before I jump in, and Jane is going to talk more comprehensively about some of the others. Our group, we have a key populations program in our center at Hopkins, which is led by Steph Barral, a terrific Canadian investigator, has used this definition, right? What makes a key population key? It's two things. One is either a high burden or a high risk of acquisition, so that's kind of standard, everybody knows that, and a lack of access to essential services. And both of those things together really are the drivers here. So, you know, obviously, if it were a fair and just world, the people with the highest risks and the highest burdens would have the highest rate of services, right? That's what equity is. That is not what we have. And if we use that definition, what comes out is gay men, sex workers of all genders, people who inject drugs, transgender women who have sex with men, and prisoners and detainees. And then these very specific populations of women and girls in South and Eastern Africa, of course, uninfected partners and discordant couples, and very importantly, adolescents from all of these communities, right? You look at who meets that definition of the highest acquisition risks and the lowest access to services, adolescents are always jumping out. So let's talk about drug users. You know, there was a great deal of work early on which had enormous gains in this area. In Baltimore City, where I've lived and worked now for 2 decades, we haven't had really significant rates of new infection among people who inject drugs in 20 years. Success of harm reduction, drug treatment. I mean, this is a problem that actually is solvable with the tools we have. However, explosive outbreaks continue. I'm just showing you 2 here. This is Greece and Romania. In both cases, a structural problem. In the case of Greece, a financial collapse. In Romania, a pullout of the Global Fund, and just really rapidly explosive recrudescent epidemics. And those epidemic curves looks kind of like Yunnan in the early period. We've seen this before with IDUs, and now, of course, this is happening in rural America. Scott County became a kind of iconic, this is in Indiana, where, by the way, having a needle and syringe without a prescription was a felony with 3 years imprisonment and a stiff fine, right? So not just that they weren't doing needle and syringe exchange, it was a felony, right? And the people engaged in it were engaged in felonies. So a very explosive epidemic there. And I think one of the things that's very striking about Scott County, and now this has been shown across Appalachia and Western Maryland and in so many of the places where this opioid epidemic is happening, is that we really do have an increase in injection drug use. This is a very nice analysis from Tang et al., just very recent in the New England Journal, and it's looking at estimated numbers of new HBV and HCV infections by year in the United States, right? For those of you who are skilled in infectious disease epidemiology, that's an epidemic. That's what that is, right? That is an enormous increase in infections, and that, of course, is driven by a spread of injection drug use. And this is an enormous challenge because if you look, won't go into the details of it here, but if you look at the geography of this, this is not the urban cores where we have all done years and years of work in injection drug use, minority populations in inner cities. This is, you know, Scott County is, the capital of Scott County is 4,000 people. These are rural areas, low income, post-industrial, very, very challenging places to respond and provide services. So Stephanie Strathi and I were asked to write a policy piece for the New England Journal about putting forward essentially what should be the response in Scott County, which we did. And we thought we should break that out into what physicians and providers could do to respond and what the state should do. And I will tell you that not all these things happened, but happily some of them did. Here's a question for the students out there. Who is the governor of Indiana when this happened? Who knows? Mike Pence. That's right, that's right. And Mike Pence actually broke the Republican stranglehold on needle and syringe exchange and allowed it initially to happen on an emergency basis just for a month, and then eventually allowed it to happen across Indiana. Which was really an extraordinary change. And of course, finally, just at the end of 2015, the federal ban on needle and syringe exchange was lifted across the United States. Funding now is allowed across the United States. And who led that effort? Anybody ever heard of Mitch McConnell? Yeah. Because his state, of course, was one of the very effective ones. But if we look at this globally, we see the same thing, that there are enormous restrictions on services and basic services that we know work. We did a commission, a Johns Hopkins Lancet Commission on drug policy and health for the last UN General Assembly in 2016 that was going to be looking at drugs for the first time in a generation. And what you're looking at here is a systematic review, meta-analysis of data at the proportions of people who inject drugs, so PWID, living with HIV, who are on antiviral therapy. The time that we did this, and it's up through 2015. So what you can see in Western Europe, North America, and Australia is that it's really very good. High levels of coverage, and in many of those places, easily achieving 90, 90, 90. South and Southeast Asia, 5% or so of people, drug users living with HIV on therapy. This is Eastern Europe and Central Asia. It is less than 2%, right? And by the way, that's the region where the epidemic is exploding, and much of it is in injection drug users. There also are emerging couple of countries, Kenya, Tanzania, Libya, in Africa that have IDU epidemics, and you have to actually use a scale to go down. It's less than 1% coverage there. So if you want to talk about discrimination and exclusion, that's what it looks like. That is discrimination. And what happens again and again in those countries is that people have to be drug-free, sometimes for 6 months, sometimes for a year or longer, to get on antivirals. And then, of course, there's no methadone or buprenorphine or other drug substitution, right? It's illegal, or it's only available in a very limited number of places, only can be prescribed by an oncologist or a psychiatrist, and you have structural barriers that are at the heart of these problems. So this is my totally not comprehensive, blue sky thinking list of some of the research areas to address these problems. And again, really talking mostly at the social and structural level. So there is an enormous lack of integration of services for people living with HIV and for drug users. This includes harm reduction, substitution therapy or medically assisted therapy, HIV treatment, and overdose. And we're just beginning to see co-location of those services. There's a number of intervention studies underway, but this is a very important service delivery agenda. And that includes, of course, safe injection facilities, which hopefully are going to be coming and which we're going to have to assess and really look at the public health impact of these. We can't wait for that research agenda to become real, right? Let's hope. And then, of course, there's this whole area of substance use risk for men who have sex with men. CHIPS is very well poised to work on that. This is an emerging area, rather strikingly, after not being an issue, for example, in Southeast Asia, where there is chemsex, which we think of as something people do in London, is a booming part of sexual experience of men in Southeast Asia. And I think in those kinds of challenging contexts that we have not really begun to work on the network level aspects of this, right? So HIV and these kinds of substance use and the kind of behaviors that are associated with them really happen in networks. And yet so much of our research and so much of what's going on in that region anyway remains really at the level of individual risk. And of course, those networks are virtual as well as physical. That's also true of HCV. I just got an alert this morning about rising rates of HIV in MSM not living with HIV. We already knew that this was a problem in men with HIV infection. And then, of course, there's the opioid crisis. And that was a subject of a lot of discussion yesterday. As I said, this is a challenge for us, for many of us who are focused on, for example, Baltimore City, just to make it local for me. We didn't realize until we had an outbreak in Western Maryland that needle and syringe exchange was only legal in our state in Baltimore City. Because basically the legislation that was responding to a much earlier epidemic basically agreed that we could do it in the city. What has been happening without people really paying attention is that drug users from the county and rural areas have been coming into the city to get clean works. And of course, that also plays a role in other kinds of interactions, drug trade and disease spread. The challenge around, for example, doing epidemiology, doing prevention, doing services in these rural and low burden areas is really, I think, a major one. And it's not going to be easy to do. And of course, we're going to have to adapt the interventions many of you have worked on in urban settings for rural and suburban use. And that's going to be a challenge too. And we're going to face a lot of NIMBY issues. All of you know what NIMBY means? Not in my backyard, right? You think that's tough in inner city areas? Wait till you try suburban Baltimore. Nobody wants a needle and syringe exchange. And I think obviously there's a huge research agenda around overdose. I'll just say that we, for example, have recently embarked with our CFAR, and Susan Sherman has been leading this up, on fentanyl testing. And simple kits that drug users can use to test their own drugs for fentanyl, right? Very important area. And there's going to be, as there has been for naloxone, a whole set of issues about how we research the distribution. I got to move a little more quickly. And obviously there's policy and reform implications there. And there is a rich agenda on decriminalization. And there's some emerging work, for example, on decriminalization of cannabis and overdose impacts, which has also been really, I think, exciting. And then I spoke with a number of colleagues yesterday as well about the rehab release dynamic incarceration, the continuum of care, both for people with HIV and drug treatment in and out of rehab and release. This is I think, really a critical area. and obviously post-release and overdose. And then for many communities, there is a social research agenda around the impacts of mass incarceration that really interdigitate with everything we do. And I would just close this part by saying, unfortunately, that we have some other trends that are going exactly in the opposite direction. So many of you will know that our Attorney General, Jeff Sessions, just last year directed a federal directive to all federal prosecutors to seek maximum penalties in every possible case. Right? So that really has reignited the war on drugs. That is going in precisely the opposite direction that all of the public health data would suggest we need to do. Of course, that doesn't really include the people, for example, the manufacturers of OxyContin, who have probably had the biggest role in this opioid epidemic and made the most money off it, and of course are getting off. So I have to speed up. I'm going to go quickly through MSM section. You all know, this is men in the United States, the most recent data from the CDC, that male-to-male sexual contact actually is the driver for men in the United States. It's a huge proportion of our epidemic. I want to talk with you a little bit about work that we did in Russia around this issue because it's very little known. We set up the only safe and anonymous HIV testing center in Moscow, city of 12 million, for men who have sex with men. At the time, Russian reporting of HIV prevalence in this population was 4%. We did a respondent-driven sample and compared it to an internet sample and found a crude prevalence of about 15.5%, with RDS adjustment about 12%. It's interesting, the Russians immediately changed their reporting data and went with this number, even though it's just Moscow City. I just want to show you the power of this tool, which is really very exciting, is that we just did this out of one clinic in a respondent-driven sample, but this is the Moscow City and Metro system. And where our recruits were from, and you can see that if you do that right, you really do capture the whole city. But this is what I wanted to share with you. We're all so concerned about the continuum of care, and what you're looking at here is all the men who are living with HIV. We found a couple of hundred, unfortunately. Having ever had an HIV test was really pretty common, but then look at what happens in terms of actually having a diagnosis, right? So this is one of those examples where the first 90 getting diagnosed is a cliff that people have fallen off. This is RDS adjusted and weighted. Linkage to care actually not that bad, but then currently on therapy is terrible, and at the end what you get is that 3% of people are virally suppressed. That's not going to control this epidemic, right? And I will just say to you that this clinic was then subsequently shut down with the new anti-homosexuality propaganda law, and with the law that Russian NGOs, who are working with 2 NGOs, have to be foreign agents, where they can't accept US federal money. I'm going to skip this just to say that we have an array of new tools, right? And just remember, this is old stuff, right? This is HIV testing, linkage to care, treatment, right? Nothing revolutionary, but not happening. We now have a wide array of new choices, a number of which are being investigated among gay men and other MSM, including, of course, here with Rafi's thrilling work leading the cabotegravir injectables. But all of these are going to happen, if they happen, in the same context, right? And in places where we are seeing actually restrictions on access and on rights. So what are we looking at for gay men? I think one of the things that's been so striking with PrEP and really so disturbing is that it has uncovered the disparities that were already there, and it actually has worsened the health disparities for African-American MSM, Latinx MSM. And so there is obviously a critical research agenda. How are we going to start changing that? And that is particularly true also for adolescents from those communities, right? I think we need to understand a great deal more about how TASC and PrEP are going to work at network levels and in populations. Because there is a little bit, I'll show you one slide from the UK, evidence that if you can do both of those things in MSM networks, you really can reduce new infections in a powerful way. And that has to go beyond the individual. I think there's an implementation science research agenda around that. There's a lot of work on recruitment and retention that really needs to be done. There's some new epidemiologic tools out there, but also there's a huge amount of work on social media recruitment platforms. You probably know the NIH just funded this new effort, the Light cohorts, which is all going to be technologically based. This is meant to be the next generation beyond things like the MAX. And it remains to be seen if we can really do recruitment and retention in cohorts over time just using these platforms. Obviously, there are big stigma reductions for LGBT around PrEP, around strategic litigation. We've been doing a lot of this in the Caribbean, actually. We did the amicus brief for the first big win in the Caribbean, decriminalization in Belize, which has really been a game changer in that region. There's a huge adolescent agenda, obviously, school-based interventions, unstable housing, that a lot of you are working on here. And then just to say, I think for all of those novel interventions that are coming down the pike, we have to try and do better to make sure that these two don't add to the health disparities and that they actually start to address the health disparities, right? And that, it seems to me, is an enormous challenge, and we're not there yet. And in this area too, we are not going in good directions. So you may know that under President Obama, Secretary Clinton, and then John Kerry, the US actually established a policy which has been in place, and it still is, don't tell anybody, it's there, you know, it's one of those hide, that sexual and gender minority folks who are being persecuted because of their sexual orientation and gender identity can seek political asylum and protection of US embassies and consulates around the world, right? That is a sea change. I remember being engaged in this battle when Condoleezza Rice, Secretary of State, stood up and voted with Iran to maintain criminalization of LGBT people, right? So this has been a sea change, but we are going backwards. And Human Rights Community Outreach International is the new organization that came out of IGLHRT, the International Lesbian, Gay Human Rights Commission, really calls this the Trump effect, the emboldening of anti-gay policies and practices worldwide. Unfortunately, that too is a mark of where we are. I'm just going to close this by saying it's rare in public health and in clinical medicine that WHO ever says anything simple. But occasionally they do, right? And this is the most recent guidelines, right, from 2015. Treat all people living with HIV and offer antivirals as additional prevention choice for people at substantial risk. That is so elegant, right? But buried within that is this enormous set of issues of how we are going to do that for the people who need it most in environments where there is not support for those activities, and with all of the many challenges and intersectionalities that those people face. And that is a simple set of steps that need to be taken and an enormously complex effort to get it there. And it's going to require the next generation of HIV researchers. I think I'm talking to that next generation, which is very, very exciting. So I'm going to close there and thank a bunch of people, and thank you for your attention.
So one of the nice things about what I get to do next is I get to introduce my friend, Jane Simoni. I've known Jane for a lot longer than I'd like to say. I was her clinical supervisor when she was a second-year graduate student in psychology here. So it's wonderful to see how well you've done, Jane, and gone out and just like taken control of the world. It's great to see. So there's a little bit of a personal there. It's always good to see you. Jane is a clinical psychologist and a professor, full professor in the departments of psychology and global health at the University of Washington in Seattle. Yes, well, please come get food, everyone. So we don't want to have food. It's going out, not eaten. So she is active in the UW CFAR and leads their behavioral science core. She also leads the Network Behavioral Science Consortium, the network, HIV/AIDS Network Coordinating Committee's Behavioral Science Consultation Group, kindly and lovingly known as HANK. So she's the co-director there. She's got an international work portfolio, done an amazing amount of work over the years, and it's my great pleasure to have you, Jane, come talk to us about behavioral interventions on the way to 2020.
Unmute my speaker or increase volume. I'm good. I thought Chris had broken the equipment. So, I did want to thank Steve. As I was familiar, we were thinking of a story of him. I was going to mention he's our first clinical supervisor, and I will say it was 30 years ago. It's okay. Age empowerment, age empowerment. Not ashamed. In one of his cases, we talked about someone was having trouble connecting, opening up, and so Steve said he took them over every morning before they had their session. They walked over, got a coffee together, casually walked back to the room, and then they were able to talk together. And from that, and Steve's work later on, and the work I've seen him do over the years, I've learned two important things. Try to do work that is outside the box and that has a real impact on people's lives. And I thank him very much for that. It's inspired me in the work I do and the work I hope to be able to do. So thank you. Thank you, Steve. Chris set me up great at the background for this talk, because I'm going to talk, and I love the last slide for the World Health Organization saying what they thought of a simple thing, offer everybody treatment and just hook them up, and if they need it, give them prevention. And as Chris said, unpacking that is where the real work really begins. So I'm going to talk a little bit about behavioral science's role in that, just very generically, the key populations and some of their specific challenges, and then talk about some of the work I've had the privilege to be involved with to show, especially the trainees here, how do you do something like that within a research agenda? Yeah, unpacking this can seem so complex, but how can you actually do studies to test this, to see how we might move ahead with the behavioral agenda? So behavioral science, I know even doing my internship that I did here in a very biomedical setting, working in a biomedical field, in the CFAR, a lot of times behavioral science is kind of thought of. They don't really say this outright, but I know Jared Baton heads our whole CFAR, was at a meeting recently, and he also has his PhD in Epi. So they'd separated the docs from the other folks, and he was in the other pile. At one point in the day, they referred to the scientists and then the non-scientists, the ones that didn't have it, and then MD. So Jared didn't like that very much. A lot of our work is seen as the soft science of the social sciences. But I think it's actually the hard is in the difficult science. It's hard to measure the constructs that we do. We're dealing with human behavior, and that frontal cortex doesn't always do what you expect it to. You can't put people in a little maze in the lab and study them. You can't assign them to groups that would be unethical. It's just very difficult to study a lot of behavioral science. And of all the chemo treatment, therapy, and chemoprophylaxis that we have, all of it involves humans. And anything that involves humans involves behavior. So just about anything, even if we do have a vaccine, right? Even if we do have a cure, you have to tell people about it. They have to come forward to get tested. You're gonna have distribution networks. They're gonna have to overcome the stigma to be able to take it, to come back if it's more than one dose. So there will always be a behavioral component for folks. And I just summarize that. Maybe the theme of this talk is, even the original title of the talk was going to be, getting to 2020, what are the challenges, the biomedical revolution. And I suggested, let's think about it as biobehavioral. It's a term that's being used more and more. And as I just explained, it's really hard to think of any biomedical intervention that involves a human being that really isn't a biobehavioral intervention. So it's just a little change in terminology that I think goes a long way when we think about these things. The key populations, some of which Chris talked about in detail, that I'm going to cover a little bit more specifically, have something in common, right? They're all the marginalized, disempowered populations. And HIV can do that, can go into a society and it seeps into the cracks, the inequities of the foundation of the society, and it finds the most vulnerable. And it's very good at doing that. And HIV has done that with the people who are least have access to services, most subject to oppression systematically. And those are the folks that we're not quite reaching yet. And as Chris said, as we get closer to the goals, it's harder and harder. I sometimes tell my students, when you're writing a paper, you think you're almost done, you have about 10% left. I said, it's that 10% that takes 90% of the effort, because you're not as close as you think until you really try to finish the job. So some of the key specific challenges that I'll go through: pregnant and breastfeeding women actually have poor ART adherence and retention and care, especially in the critical postpartum period. It's their home, the infants. There's gender inequity that they feel in the case of partner violence, which is increased during pregnancy, the stress of pregnancy. And postpartum, the physical effects of the pregnancy, postpartum depression, stress, fatigue. There's about a 30% chance of at least one viral rebound during this period, and lack of social support, even with male partner during this time. Particularly the transition to non-services, prenatal care, to general HIV care tends to be very poor as well. For children, there are missed opportunities right off the bat for early diagnosis, with limited pediatric and palatable pediatric formulations for kids. Caregivers need a lot of help to be able to care for children. Only about 50% of children with HIV worldwide are on ART, according to one 2015 estimate. They do have poor virologic suppression, and for the parents, a lot of this is the fear of HIV disclosure. Adolescents, those of us who know from the science of research on this group, and those who have, like myself, a 15-year-old in the home, know that adolescents, you can't live with them, can't wait to live without them, because there's something about that developmental process that they're going through that is exactly at odds with self-management of a chronic illness like HIV. And the more and more they want independence and control, the harder it is for them to do it. I've heard some of my adolescent adherence experts say the field is going to have to get used to the fact that we are not going to achieve a 1999 with adolescents, which is never going to be as good as we want. We have to come to terms with that. It's very difficult. We have to do the best we can, but we have to be realistic about what we're going to be able to do with kids. So the poor linkage, again, a lack of disclosure to kids who have been perinatally affected is still a problem, but thankfully less and less. If we talk about developmental limitations, and then again, the transition to healthcare. The kids at 20, 23, 4, 5, they just want to stay in the pediatric clinic because the cares is so different when they go on to the adult clinics. That's very difficult. For MSM, Chris talked a lot about the high community prevalence. So it's not behaviors that are necessarily different. You're doing the same things that other folks are doing, especially in communities of color for MSM, but you're acquiring HIV at a much higher rate. The stigma, the early trauma, because a lot of discrimination, a lot of early childhood sex abuse, which differentially impacts gender and sexual minorities, their mental health and substance uses, and that the trilogy or the syndemic that Ron Stahl has written about for MSM. There's criminalization that's still worldwide, including in Uganda, where it's a death penalty for men who are found to have sex with other men. Non-disclosure issues, folks not identifying as a sexual gender minority, which made it hard, especially early in the epidemic domestically, to target folks that didn't see themselves as at risk. And then social isolation as well. Transgender women who have sex with men, all the same issues as they have it with MSM, but even more acute in a lot of ways, and not able, in terms of disclosure, sometimes not able to pass like some MSM can. So it's even more difficult for them. I know it's a picture of a Native community. I work a lot in the Native American community with my partner, Karina Walters, and there's a huge mortality rate for transgender folks are out in the Native community, and about at least a third of 40% are HIV positive. Sex workers, again, the stigma, gender-based violence, criminalization of their work. There are financial incentives for not disclosing of HIV, of course, and then for not using a condom. You can make more money this way. And they can be now, with the use of digital technology in sex work, there can be hidden populations. So there's an issue in China where I do some work with, there's a population of retired men who have access to the internet and have contact with sex workers, but it's very difficult to do an intervention because there's no one place they go. There's no brothel where people are set up. It's all on the phones. They can meet wherever they want. They take Uber or Lyft type transportation to get there. So it's very hard to trace, very hard to track, very hard to have make any kind of impact in that area. Migrants, refugees, immigrants have very late entry into healthcare, often don't have access to the care. They don't have local rights to do it, like in China with the hukou system, or lack of direct access or any kind of insurance to be able to do that. They're exposed to difficult, oppressive, unsafe work environments, which they're afraid to talk about because they're afraid of being reported or deported. They're separated from all their social networks, often in a familiar environment, and not to mention they can't often speak the language and ability to communicate, always at the risk for deportation. So very hard-hit and marginalized group in terms of HIV. People who inject drugs, Chris talked about mainly, and don't forget prisoners, of course. And for research, I always thank people who work in the criminal justice system because it's so hard to do that kind of work. And Fred L.T. said recently he could do it more easily doing internationally than he could in his own country. So a lot of important work isn't done because it's very difficult to do work in prisons. So opportunities for behavioral science. As expert of the talk, I'm just going to talk about some studies that I've worked on and some of my colleagues at the University of Washington to give you a sense of what we might do in some of these areas. And they involve a lot of strategies. These are the ones I focused on: promoting adherence, mental health treatment as a way to promote adherence, engage people in care, what to do about disclosure, both disclosure to others and then disclosure to your own family, children that you have HIV, how to reduce stigma, which is very difficult to do, and also involving providers, HIV providers, in education and training. So I'm going to start with some domestic programs that we did. One of the first was Project PAL, which I started in New York and then brought to Seattle. I'm going to go through these slides very quickly. You can get copies of them later, but I'm just going to make a couple of points about each one of them. Trainees, don't do this. Don't do too many slides that you can show, but I just want to give you an example. Once you know the rules, you can break them. But you can have access to these. I just want to make a couple points. So we used peer support, which I'd always, from my earliest days in graduate training, thought was very powerful. We're never going to have enough access to professionals, so using some kind of task shift on the peer support. And this is for those of you who were born about the time I did this study. These are pagers as kind of electronic device where you can actually call other people without the use of a telephone. And we used it as a medication reminder for people to take the pills that they were taking. We recruited 223 people in an outpatient clinic and followed them for 9 months when they were on the study. We did see some results. Some of the peer support group, they were, at least in terms of self-reported adherence, and even some of the pager intervention was able to impact some of the biomedical outcomes. It's important as much as you can to, of course, to measure the biomedical outcomes as well. CDC has a compendium of best practices you should look at. If you're not familiar with it, a couple of these were listed there. And like every intervention, behavioral intervention, has to be modified, has to be adapted. So CDC has already done this by combining this and a couple other interventions to a technology that some of the young people might actually recognize in the room. And so using a smartphone that has some of, but the mechanism is the same. When you're doing e-health, you want to do the mechanisms of action. How do you think it works? Not just the actual program or technique, because that's going to change. Before you finish the study, that's going to change. It did with us. So the implications, you could actually use peers to help out. They can function both face-to-face and via the phone. And technology can supplement human contact. It can be highly automated, and now it's even less expensive, a lot less expensive to be able to do that. But there are problems too. I think peer support's helpful. We move the bar maybe a little bit. I used to say in one review of adherence interventions we wrote that it helps a little bit for a little while, but when you want to do more, you have to have something a little bit more in depth than just the support or the shoulder of a peer. So the next study was on the US-Mexico border. What we went down and did some early formative work, and they said the issue really was depression. And people living with HIV, a lot of the MSM were, depression was the main issue that they were dealing with, the main barrier, the main challenge in getting on antiretrovirals and staying on. We asked if they wanted group support. No, we want individual counseling. It's really what we need. There was so much stigma. It was important to them. We borrowed a program from Steve Safran's CBT-AD, which was CBT for adherence and depression. Found if you treat them both at the same time, there's a synergistic effect. It's better than treating either one. And we trained graduate students to be able to do this intervention. So we didn't have to have high-level professionals. And they're desperate for this kind of information here. We had a talk for continuing education credits for folks in the area. 100 people showed up to learn anything that was evidence-based because they just did not have access to it in the community. There were 3 psychologists who went down there to work. One didn't have a license, one had lost his license for unethical practice, and the other didn't speak any Spanish. So it's not, that was this is in the US, right? The limited resources we were up against. So we had an R34, it was a pilot study, about 20 people in each arm that got either standard care, a letter to their provider if they were depressed, and then this treatment program for about 16 sessions. We found that the results, it wasn't powered for efficacy, but we did actually see some significance in reducing depression, both self-report and how we assessed it, and self-reported adherence. So we found you can adapt. intervention for a community. There are ways we had to do it specifically for the community. We had to consider the context in what we did. We had to add an entire module in the beginning to talk about religion, homosexuality, the involvement of the family, social support, which wasn't any part of the intervention originally. And again, we found that you can, again, task shift, that graduate students could learn to do this very effectively. I've done some work in China, and I want to tell you about a few projects that we've done there. The first one, we also wanted to have some kind of counseling, that we were concerned with the stigma and whether people would be willing to talk in China. There's an expression they say in China about people from the West, that when they open their mouths to speak, you see all the way down to their stomach. They tell you too much TMIs, too much information, too much disclosure, things that, and my Chinese colleagues tell me there are actually some more explicit sayings, but that things should be private. They should stay in your family. You shouldn't talk to a counselor. You shouldn't certainly tell your provider what's going on in your life. So when we thought about doing a counseling intervention in China, we didn't know if people would talk at all to the nurse. Ends up, because that community, I think there were very few options to doing that. They were very popular, and they wanted to talk. The nurse actually had a cell phone that they used for the clinic. That was a number people were texting and calling all the time. They were desperate for the kind of communication that we could provide in a kind of counseling intervention. Again, we had the nurses do it this time, not peers, but nurses this time. We borrow from Steve Safran's Life Steps program, and you can see, again, we had to add a family, community, social support, privacy section. It's a very big part of the intervention, where Steve, who started most of this work in the Northeast in the United States with mostly MSM, didn't have to address these issues as much as we had to in China. So again, 2 or 3 sessions with nurses. We did an R34 study, about 70 patients, about a 13-week intervention. We did adapt it in other ways. We offered to do some kind of electronic monitoring. This time we said, simple as possible. We're not going to give you anything special, pager or a phone. Most people had smartphones. We showed them how to program it if they didn't know or weren't using it for adherence. We invited them to bring a partner in. We didn't insist that they did, but we invited, if they wanted to bring someone in, that they could come for the sessions as well. We followed up. We did see some results in self-reported adherence. The viral loads dropped for everybody, did not show an effect, and a little better adherence according to electronic monitor as well. So again, we found that we could adapt this to another population, that folks in China would use counselors, or would come and talk to a nurse. They were receptive to training. The nurses loved being able to do something that took it, in which gave them a lot more patient contact than they normally would have. And the technology could help, could assist with the intervention, even if not do everything by itself. Working in China, there are a couple other problems that came up. When we asked for one of the studies, disclosure was a big issue. Not like in Africa with kids who were positive. These are the parents who are positive, who have children who do not know about their HIV infection. And this was an issue, not because they always wanted to tell their children. They often didn't think it was appropriate. They wanted to keep, again, with kind of privacy and of information, didn't want to burden their children with their own problems, but it was a big stressor for the parents to have to wonder about this. What am I going to do? When am I going to tell them? So we came up with intervention 3 sessions, again, that nurses were able to provide, in which they would talk with the parents, give them some didactic information, teach them about the stages of children, developmental stages, and what you can tell them at each stage, and then help them come up with a plan, not necessarily for disclosure, but for managing their own anxiety about the disclosure. And Deb Murphy from UCLA helped us a lot with this. So you guys can see here, you don't read Mandarin? Trainees, Spanish or Mandarin, you better learn one or the other if you're going to continue to work. This is to remind me, actually, of the, to tell you that I should talk. I've worked for 13 years and I still don't speak it. But that there's a range, and this is again how you adapt an intervention. We didn't want it to be, you have to tell your children that's what the best thing, we've determined this for you, have you done it or not? This was like, okay, I understand you're having distress. We call it disclosure distress. What am I gonna do? My kid's gonna find out by accident. What if I die? Who's gonna take care of them? So we gave them a continuum of disclosure. You're not saying anything at all, perhaps telling the child you have some health issues, all the way to clear and open disclosure about this. So we, and that was part of the intervention. Where would they fall on that? At the end of this study, we found that it did overall, the intervention condition did drop in terms of the amount of disclosure distress they had. They felt more efficacious than the control group in being able to talk about it. And they actually did disclose, at least some extent, along the continuum about their HIV infection. My graduate student, Joyce Young, wanted to go a step further and talk not just about disclosure, but see if you could do some kind of counseling intervention that would directly address the patient's own distress about their own disclosure, especially very early in the HIV diagnosis process. We heard terrible stories of people that would go home to their families, or sometimes the doctors would tell the families that they had HIV. They didn't even get a chance. They were kicked out of their homes, had no places to go, didn't want to tell anybody about it, or hadn't told anybody about their HIV. So this is a way that we're going to use a evidence-based program of counseling to be able to do a 3-session intervention with folks in the clinic. So it's very available, low burden. Again, we could train, Joyce did the study herself, but you could train a master's level, probably person to do it. I'm sure nurses could be trained to do it as well. But again, we use, I won't go through it in detail, but we use basic CBT kind of principles, all evidence-based, that were translated culturally with examples of what could be used, and some things that were more cognitive, some that were physiological. We did a paced breathing kind of exercise, so that could be addressed as well. I'm doing front time. And found some good outcomes, even a very small pilot study that lowered depression, coping was better, less distressed, and in general, they were able to function better in terms of their HIV diagnosis. The final study that we're looking at is using completely task shifting for we don't have any personnel at all. What can we do online? Can you really treat mental health without a person? Can you look at some of the disclosure distress? Can you look at depression? Can you use these evidence-based treatments and do it with an online program? We're seeking funding to do this, but we have a program developed that has 8 modules that incorporate a lot of what we've done in China so far. And we're going to test whether it's best to do it with a nurse, which we think it probably is, or if this is something that once we show it works, we can put it on the internet and just give it away. Haiti is our current project that I'm working with Nancy Puttkammer. This time we wanted to think about what we could do with the provider in terms of reaching the challenges of being engaged in care and in adherence. We had 2 parts to this program, taking advantage of an electronic medical record, which they have actually a very good one in Haiti, and we came up with an alert. So if people have a CD4 count or an HIV or a viral load test, which is rare, we can tell whether they're successful. We can tell whether they're a success or whether they're a failure. It's in here that we'd like to be able to identify patients early on. So with the alert, based on, this is an algorithm that we developed based on years of data, based on a couple of risk factors, and men were more at risk, age was a risk factor, late pickups for pharmacy records, those kind of things. We could see whether they're medium, high, or minimal risk, actually, for having a viral load. And then we came up with an intervention. I didn't want to do a very strict, we used a problem-solving approach, but I didn't think within the Haitian culture that a very writing something down, checking boxes was going to be the most effective thing. We wanted it more engaging. The Creole speaker communities we were with had a very strong oral tradition, very friendly, very outgoing, and we did some very kind of basic training with the providers and how to take advantage of their communicating with their patients. So a problem-solving program, which we started very simply saying, tell us about a good day when you're able to take your medications, tell us about a bad day when things don't go as well. We're able to identify a problem and then address it in 5 steps, coming up with possible solutions and seeing if that would be a way to behavioral influence, whether they could take their medication. That study's ongoing right now. I'm going to end up with conclude with a couple studies in Kenya and then a couple stigma prevention studies. I'm working with Susan Graham for a study in Kenya. Again, this is MSM. So she's done, one of the investigators who's done some of the first work with gender and sexual minorities in a very stigmatized setting on the coast of Kenya. And we came up with a Shikamana intervention that's based in peer support, but goes a little bit more. It kind of combines everything we've learned so far. Because we learn, you kind of get what you pay for in terms of the study and like other things. If you have a little minimal intervention, you can have a little impact. But when you start to look at, as we said, that last 10%, you're going to have to invest a little bit more. So this involved the sensitivity training of the providers, patient-centered care at the clinic, motivational interview with providers, and counselors that we trained, a peer support group as well that also worked a lot digitally with their phones in terms of texting and WhatsApp communications, and then also mental health screening and support that took place at the clinic. We enrolled in our 34 of 60 Kenyan men and found some good results, actually even a viral load effect. We're looking now at doing the next study to find out what were the mechanisms of this. Were we able to impact substance use, or was it depression or mental health? What really helped folks to be able to adhere to their medications and be more likely to receive viral suppression or achieve viral suppression? And this final Kenyan study is with sex workers, women at risk in early diagnosis with HIV for a viral rebound. And we developed an interactive theory-based short message intervention. So we know about the Well Tell program in Kenya, where we asked people if they were doing well. And this, we wanted to go a little bit more and provide some support, some informational support, some encouragement, and some behavioral suggestions to help them taking their medications. This also is ongoing. We hope to have some results. It's kind of difficult with the recruitment, but we should have findings in time for my students' dissertation, I'm hoping. 2 more studies. I wanted to talk about stigma. Stigma is so hard. If you notice that key populations, there wasn't a single one that wasn't impacted by stigma. But what do we do about stigma? Societal stigma, internalized stigma, enacted stigma, which you experience as discrimination, is very difficult. I'll give 2 examples of work we're doing at UW about this. First from Deepa Rao and then Michelle Andrasik. One is more an individual group level, and the other is more community level. The first at this individual level is called the Unity Health Study, based on her K Award and then an R01. She gets African American women together in a group to talk about HIV stigma. They did a very well done, a professionally well done video that actually talks about a little scenario of women talking about an HIV diagnosis, and that stimulates a conversation around it, where they provide each other with support. She's done some early work in that. She did it in Chicago and Birmingham, and did a randomized controlled trial. Had a very high bar to compare it with. Looked at women who had breast cancer, did a breast cancer education intervention around it. It seems like the results of the study didn't show a clear effect for the stigma reduction, but what it was clear was that the social support, being able to talk to other women in a demographically similar situation, was very effective for all of them, and they kind of all improved. Finally, Michelle's study, in Black MSM communities in Seattle. How do you reach men to encourage testing and to translate research that we know on sexual networks into a message that will help them be less at risk? So she took a very complicated study from Martina Morris's work, showing that concurrency is a risk factor for HIV, and worked it down to community messages that she could portray to people. I'm not going to go into them in detail, but showed that you could take a higher level scientific concept, but think about a way that you communicate it with people on a broad level so that they could benefit from it. And then also these social media campaign messages. So of folks in the community, he has 2 girlfriends and he has unprotected sex with both of them. It's called concurrency, and it's spreading infection. And the idea was to get people talking about this and to click on the links that were on the social messaging to be able to help have some impact on the epidemic. So the path forward, again, the theme of this, from biomedical to biobehavioral, if that's the only thing you take away. There's really, for human beings, there really is no purely biomedical intervention. The good news about that is it really encourages interdisciplinary research, which you know is being done at CHIPTS and in UCLA in general, encourage people to keep involved in that path. A nod back to the NIH priorities that Chris had up on board. I noticed always in the low priority, which some of we behavioral scientists call the no priority, what feels like category, is always the behavioral and social sciences. And you can bet with our Hank committee that we're going to be writing in for that open comment period and say, like a study that was done recently at UW, they're doing developing a long-acting treatment. And as part of the PAR, they said it had to have the acceptability piece. Jay's working with us on that. So explicitly saying that you need some kind of interdisciplinary work. If you're going to build it, will they come? Who's going to participate? What are going to be the challenges? Michelle Andrasik's done that at UW also. They had the new study with infusions Were the men going to be able to come for this immune constitution? And before they even started, she went out in the community, educate, get people's perspective, find out what acceptability is. And then when it comes time to recruit, you can have a much more successful study. In this framework that we used for our CFAR behavioral core that Paul Gaston and Michael Sturr has written about, there's an actual framework for how you can combine both the biomedical and the behavioral science, especially here in strengthening biomedical product development and clinical trials. I think there's a big window of opportunity for trainees in HIV to be able to work in that field. I'm going to end with a quote from an MD. Sometimes it takes an MD to convince the biomedical community. So Dr. McKirkey is known as an oncologist. He's written The Mother of All Maladies about cancer. And he says, new drugs and treatments won't work if we don't simultaneously target human behavior. And there is no marker. There's no biopsy. There's no powerful predictive test for human behavior. Doctors need experimental tools to understand, survey, and change medicine's least familiar frontier of human behavior. I'm going to end by acknowledging my lab at University of Washington, all the support I've gotten from NIH, the participants, of course, and you can write to me if you want the slides or to get access to our listserv. Thank you.
Thanks, Jane. That was awesome. Chris, come on up. Let's open this up for discussion. Roger.
Yeah, I wanted to ask you, some years ago, we did a three-step intervention to reduce the incidence of new drug users in southern China. The three steps was: one, get the community to recognize the problem; two, get them to accept the responsibility for the problem; and the most important part, three, have them design the intervention. And we found in the studies in China and Vietnam that we were able to cut the incidence of new drug users by 50 to 75%. We went back 10 years later to see if, in fact, this intervention philosophy had persisted, and found that it had. So, two questions. Your feelings about community intervention, where the community actually is the major designer, and two, long-term evaluation about whether these evaluations really work.
Yeah, good questions. Want me to start?
Sure.
Great. It's great to ask the community, of course, to be involved. Most of our work had a pilot phase or a formative phase in which we did that. I think it's a lot to ask a community. It's hard to come up with a new original intervention. I think working with the community is the best model to do it, saying, this is what we know. What do you think about that? You know, what do you need? Okay, we have these resources. I can't expect the community to come up with something on their own, but I think it's important to have their opinion. It's funny what you asked is, Steve and I were having a conversation coming over here. What should be the litmus test for the success of a behavioral intervention? Should you do it once? Should it be like a medical cure? You go in and just do something, you come back, it should be all done. Or with the case of a lot of behavioral problems, which are really unremitting, right? They're episodic, chronic kind of problems. Should we expect that you're going to need ongoing treatment and support? And I think it depends on the problem you're addressing. With something like long-term chronic adherence, depression, substance use, they're really more chronic conditions that might take different types of interventions at different points in a person's life. No,
Yeah, I know that work, of course, of yours, Rogers. I would just say, I think for some of the key populations in particular, that we have magnificent evidence from early on, for example, that the gay community interventions in the early days actually had a huge impact. The MACs demonstrated that, right? Spectacular declines in risk and uptake in condom use. So we know that power. I think the challenge often in this area is when people are marginalized and stigmatized, and the mainstream community may not either accept them or speak for them, and you get into difficulties. For example, Sonagachi and several others, there are spectacular examples of sex workers unionizing, organizing, coming up with interventions that make sense in their lives and that have had some measurable impacts. So I think that to me is really important, that we define who the community is and think about that and work with those community partners. I do know I wasn't involved directly, but our Thai colleagues were in a methamphetamine intervention. Susan Sherman, David Chantano, Suwat, several others did a very large study looking again at a community intervention for methamphetamine in very affected rural communities in Thailand. And that unfortunately did not work and didn't show much of a lasting effect. And I think that's partly has to do with the fact that there aren't a lot of good interventions for methamphetamine. And it's a very tough thing to address. You know, you're in a different dynamic with opiates where we have some very good interventions.
I think one of the advantages of having the community design the intervention is that you've co-opted it. They've bought in. It's their intervention. And I have to say, one of the most rewarding things is to watch what they come up with. Sitting in a rice paddy, watching them come up with something that was their idea. And it tends to stick because it's theirs.
You sound like Carl Taylor. The great Carl Taylor used to do that participatory community research method in a major way. You're going to say other questions?
Other questions? If you don't have them, I've got a whole list. No?
Kind of maybe piggybacks on Roger's comment. Jay, I really liked what you said around the technology stuff, and you kind of mentioned the mechanisms and the functions of behavioral change. And so I've been exploring that with everything and others, and I think that might be an approach where we can kind of fuse in, like, kind of test evidence of science and maybe provide those as tools with, like, these are the things we know that work, and then the community can then build around those how they implement them. So what's my question? I think my question is there a research agenda around this? Is this something that would be innovative at NIH for future funding opportunities? You know, I've submitted grants and had said, oh, we're going to do text messaging, but we're really focused on the functions. And reviewers say, oh, well, text messaging, how do you know text messaging is important versus smartphones? And I was like, no, we said it's the mechanism. It doesn't matter about the platform. So we have any insights about that?
Yeah, I just wrote an article about using theory when you're using e-health interventions and how it might be helpful. And really the point of it was, what's your mechanism? Because I've seen so many technology interventions. We worked on one for circumcision. We're going to use, for medical male circumcision, we're going to use a phone-based message to remind the person to come back. Well, the guy has a bandage on his penis. He knows he's supposed to come back. You don't have to remind him that he has to come in. So the mechanism was not that he forgot. It wasn't like something to do. The mechanism didn't think he needed it anymore. He couldn't afford the $1 ride. He couldn't get away from work. There were other mechanisms. There were other challenges that the e-health mechanism technology was not addressing. That's why I think it's important to have the mechanism. I don't know, as a long-standing review committee member, it can't be too hard on the committee. I don't know about that particular case, but I think it is a strong case to say what the mechanism is. And I think that the best applications will have that be part of it. So I wouldn't, I mean, maybe that, I'm sorry, it didn't go well with that one application, but yeah, okay. Okay, but don't give up, I would say, on that approach.
I have a related question. So, you know, we are in this great position of seeing incidence rates on the decline, the general population, right? And so when we think about addressing HIV and HIV prevention, we think about the general population. Yet all of those populations you talked about that are stigmatized, actually, they don't live in corners that have boundaries that people can choose to cross or don't. They live with us in the general population. So that's an entree to a tough question, and that is, you know, what do we think about endpoints in going forward? So traditionally, we've been thinking about HIV prevention as, you know, being able to show a significant reduction in incidence. Well, I think we're at the tail of that distribution, and we're not going to see that significant difference. So what can we think about in behavioral science to push our peers and our colleagues to start thinking more broadly about other infectious disease, other structural determinants of health, substance use, psychiatry as valid endpoints in HIV prevention research.
Well, let me say a couple of things about that. One is, I think, that there are also, of course, the endpoints around adherence and support with viral load that are critically important. And there, you have basically a validated marker of clinical outcomes in the long term, which is sustained viral suppression, in the shorter term. And that would be something great to have, markers around prevention. I think there's an emerging research agenda around HIV and STIs. And, we tried an earlier generation of basically STI interventions to try and reduce HIV incidence with HIV endpoints, which was disappointing, I think, overall. One positive study and about 9 negative ones, and maybe $500 million worth of research that didn't really, there were a lot of big trials. But now we're in a different era where we certainly see, increases in STI related to PrEP. Some of them are because of basically ascertainment that PrEP is a screening intervention that picks up a lot more STI. We're also selecting populations that are very high risk and meet the PrEP criteria, and so there's those aspects. But nevertheless, there is I think, an important future there. And the French have already tried the idea of, for example, PrEP for STIs in the context of PrEP for HIV, and that too is a research area that talk about the need for behavioral and biobehavioral components. So I think that's there. Certainly right now in DAIDS and in the thinking of many of the HIV-specific funding across the other institutes, I think for prevention trials, there still is a thinking about HIV incidence as a gold standard and that as required in a way for definitive interventions. I think the biggest challenge that I see there is that, we have expanded the toolkit and hopefully we're going to continue to expand it, and you have to keep offering that as a control condition. And the control condition is eventually going to get to the point where it is so compelling that it's going to be very hard to show a difference even with something extremely good. And that's a kind of existential design threat. We talked about that a little bit yesterday that I think people really need to think about and work on. We've already seen, for example, with the next generation of vaccine trials in African populations, that the ethical agreement was you have to provide circumcision if men want it first, and then a healing period, and then randomization and enrollment in the vaccine. So that, it's a 60% reduction in acquisition up front that's lasting.
Not reversible.
No. At least not yet.
I have 2 quick questions. One is, we in public health are constantly teaching behavioral theory, and I was just wondering, with this biobehavioral implementation science that you're involved in, are there any theories that you think are, those I'm using and are really working and want to share with us to know, like, this one is really great? And the second question I had was, when I was looking at the list of the marginalized, and I kept thinking about, we're also interested in scale up. And scale up involves governments. And governments are the worst when it comes to sex workers, migrants, all transgender. I mean, you name it, right? So I was just thinking about, where is the best connection there with government and scale up and some of these, the most marginalized? I'm not thinking of pregnant women, because I think that's not, I wouldn't necessarily put them, some of those in the same group, but the more marginalized, as it were, the more disempowered, where does the scale up piece, or is it always going to be an NGO kind of private engagement that we really need to be involved in?
I'll take the first, you take the second.
Yes.
Yeah.
Perfect. Very nicely done.
I have no favorite pet theory, but I do like to think of multi-level components to theory. So I will always refer to the ecological model, just because so much of the early theories in HIV were based on the rational man, literally man. So it was, they were very cognitive, behavioral, very mentalistic, very I'm in control of my environment. I see what the choices are. I see the pros and the cons, so I'll make a rational decision about that. And they didn't work so great, as you can imagine. When it came to sexual behavior and drug use, they just didn't take into account the factors that mattered, and especially in key populations. They didn't take into account the disempowerment. People didn't have control over their environments, and they couldn't make a behavioral choice always because it was not possible. So I like to think of multi-level model. So what other factors are impinging upon their level? It's not just, so we're looking at sex workers. We can't just decide whether they're going to use a condom or not. We have to look at their clients and what their clients, look at that as kind of the mechanism if this works or not. Can we educate the clients? Can they be involved? What about if they work in a more structured environment? Can there be a zero tolerance for not using, zero intolerance, right, for not using condoms, or 100% condom, whatever, the Thailand model. So I think it's important, the multi-level theories. Again, no pet one, but the components.
So I think we've learned something important about governments from the Millennium Development Goals. So when the Millennium Development Goals were put forward, people remember there weren't so many of them, and they were really quite focused, and one of them was around HIV. I thought, it's not going to have any traction. Who cares about that? And then it turns out within a year or two that, whatever country you're in, you'd meet the Minister of Health, and they could tell you where they were on MDG 3 or 4, and that they were making progress in this area, and they actually cared, and there was a metric there, and there was a comparator, and it was impressive. And I came to see that actually, there is a real value for governments in goals and targets, and in accountability, and in taking those steps. The most recent example of this for me, and this is, I'll just share with you, that I think is encouraging, is that, WHO has now embarked on this process of certifying countries free of perinatal transmission, right? And that is something that governments really want, and they care about. And it's and so Thailand has recently achieved that. Now, Thailand is a great example. There are a lot of people here working in Thailand, I know, because it underscores how we have to be subtle about epidemiology, right? Because Thailand has done a spectacular job of controlling heterosexual transmission, and it really is true that they have very, very low rates of perinatal transmission, and they have close to 100% coverage of pregnant women, and they have a raging epidemic in young men who have sex with men with very high incidence. And you have to understand that those two things are really disconnected. They are dislinked epidemiologically. And they could both be true in the same moderate-sized country, right? And that's important. The reason I say this is because when you look at WHO's certification process, it includes a range of very important parameters, like access for all women, like inclusion of marginalized women, impoverished women, that are measures that are really abut on human rights issues. So we have worked with a group, Joe Amon, used to be at Human Rights Watch, now at Princeton, and myself and several other folks, and the Global Network of People Living with HIV, GNP+, Laurel Sprague, who's the head of that, on trying to come up with human rights measures that will be part of the certification for 90-90-90. How have you done for marginalized populations? How are you doing for sex workers? How are you doing for MSM? And to really try and build that into the certification process, which we were all a part of at a very interesting meeting that PEPFAR funded with UNAIDS this last winter in Geneva, outside Geneva, to try and come up with the metrics for the end of the AIDS epidemic. Okay? And I think that, without those social justice measures, first of all, we won't get there. Science is abundantly clear that that is the case. And secondly, we won't have a lever that governments actually care about. But I think we do potentially have some levers. Will that move the Russians to actually implement harm reduction? Inshallah. I really don't know what is going to move them, honestly. But there are a lot of governments who care, surprisingly, about those kind of measures and about how they are seen in their region and among their peers.
So we talked a lot about the fast-moving biomedical intervention, which seems to be sometimes at the at the stake of the biobehavior. And the truth of the matter is we all know that they need each other. Because when you talk about the marginalized populations, well, let's stick domestically just for a moment. Good old United States. We're also talking about traumatized populations. I know I wake up more and more traumatized in America every day as a Black gay man. So, we were able to prove with the 073 study, the Black MSM PrEP study, that it wasn't that the men won't take PrEP, but that they need other things that addresses these structural inequities in our society, which is what the C3 client-centered care coordination piece was all about. Now, once we're able to get it out there, we'll be able to educate people more. But the question really is, how do we convince our colleagues that you really can't put one ahead of the other, that they really both need each other, especially for these marginalized populations? Because truth of the matter is, in the United States, we will never reach any of those goals unless we address the epidemic amongst MSM, particularly MSM on color, who are all multiply traumatized.
Yeah, no, I mean, that is our epidemic now.
Yeah.
That's absolutely right. I think, we've seen, and we hope that we're still in a world where the evidence matters, that, when work that demonstrates that those kinds of integrations and building, interventions that include the things that matter in people's lives and not just the things that we care about and think are important. If we can show that those work and can help, for example, get over the racial and ethnic disparities in PrEP and in treatment access and in adherence, that certainly, we hope, will be a driver of change. I remember having a discussion with a colleague actually at Open Society, Soros' foundation, who worked on sex work. And she said to me at one point, I just don't see why we need to do any more of this research. I mean, we know what's going to work. And what does research change anyway? And it was just around that, I know, God, it's okay. But it was just around the time of the results of HB. Yeah, exactly. But just around the time of the results of HB 10052, right? And, we are in a post-052 world, right? I mean, that is as a sea change in so many things. And of course, also, the recalcitrant governments too, recognizing that without addressing treatment, we went. And, remember, we're those of us who've been around this game for a while, remember when the argument was, no, what developing countries need is primary prevention. Treatment is not going to be possible, feasible, affordable, doable. Imagine that. That is not that long ago. So I think it's on us to show that actually works, and how do we optimize it, and how do we get it out there?
Great. Jane, do you want to have the last word?
Please.
What I was thinking about actually is with one of the questions, we talked about biomedical, and I think of biobehavioral as kind of a step back a little broader. And I was talking about the ecological model, and then you look at dyads and social and then structural, organizational. And with just about every public health problem, we could go all the way to the top. And so if we eradicate poverty, we eradicate racial discrimination, systematic oppression because of sexual and gender, minority status, we could solve all the problems. So where do you focus? You could always say, but you're missing the upstream, the broader problems. So you just have to work, I think, at whatever level you choose to work in based on your expertise. You have to at least work within the context and the knowledge of the other levels. I would leave that as the final word. You can't work it all at once. You can't really choose one or the other, but you can't work blindly in one because you just won't be as effective.